We have our team together. As I think you're aware, our Arkansas Payment Improvement Initiative is really almost entering into the latter part of its second year. The big push this year is going to be for the rollout and extension of the patient-centered medical homes across our state. We've got a lot of folks here in the audience that have a history of that, and we wanted to share with you both the vision of where we hope to be going as well as some of the steps along the way of how we've gone. What I'd like to do, just setting up, we would like to push through this presentation, and we've got it divided up where you won't hopefully get bored of hearing any one of us for too long, and then open up for the second hour really for questions, answers, for your input as we go down this path. We do greatly appreciate everybody's presence here today. And these are kind of the 5 things. I'm going to do the patient-centered medical home. Randall's going to do some about his experience, and I think we look forward to the rest of you sharing yours later. And then Andy's going to do some on the Payment Improvement Initiative. Bill's going to talk some about the patient-centered medical home, and we'll work Steve in here somewhere. I've forgotten exactly where, Steve, we've got you pegged. Nationally, the patient-centered medical homes have been around for a while, but I think we're looking at a new and invigorated version. Our primary care system nationwide has been underinvested in, as probably most of you in the audience would attest to. And it's left it where, for most of the public, the experience of having coordinated care as you go through the system is at best a rare event, and too often does not happen at all. Patients don't have a single provider who's helping them navigate the system and is accountable for the patient's care. And the complexity of the system and the health conditions that people have frequently are overwhelmed. We've seen over the last 3 decades our primary care providers' payment rates diverge significantly from the specialty providers' payment rates. So that we have much more investment in the specialty care, and this is something that has resulted in our PCPs being underpaid and not very well integrated with the rest of the system. And yet the patient-centered medical home has been a concept that's been around for 2-3 decades in one way or another. To have a patient-centeredness that the individual actually has, historically it's been a single clinician. In the future, we envision a team that's wrapped around them. And there's an emerging trend to implement these patient-centered medical homes to address directly the frustrations that people are having with the functionality of our current medical system. Our providers have gotten lower income, had difficulty recruiting new folks, thought about emergency medical records, and are slowly adopting it. Where we hope to take our state with your help is to meet the triple aim of improving the health of the population, the patient's experience of care, and reduce or control the rate of rise or the cost of care. And in that process, to really truly reinvigorate the primary care role by increasing revenue and by improving the practice so that it's fun to be in primary care again. The aims, triple aims that the Center for Medicaid and Medicare have put out are fully aligned with our Arkansas Payment Improvement Initiative goals to reward high-quality care and outcomes, to encourage clinical effectiveness, to promote early intervention coordination, and to encourage referrals to higher-value downstream providers. So who all is pursuing this? Currently, nationally, we've got more than 90 health plans, dozens of employers, 42 state Medicaid programs, numerous federal agencies, hundreds of safety net clinics, community health centers, and others, and thousands, literally, of large and small clinics that are adopting this innovative approach to trying to provide care. And I think it's important. This is not about a single clinician having a patient-centered medical home. This is a shift to having a team of clinicians that are working together to deliver primary care comprehensively, managing the patient's health needs with an emphasis on value being high quality, but at an efficiency and an affordable cost that we can actually make the system be sustainable over time. We envision care to be coordinated and integrated across the multidisciplinary teams so that it's not the patient that has to make sure that everything gets transmitted, that the team itself is functional in that way. That patients are linked to a primary care provider who is the leader of that team. I've used the word quarterback before in some of the conversations, that there is a quarterback on your team and that we are trying to achieve that. And that while currently only 3 to 5% of healthcare dollars are spent on primary care, we envision the primary care patient-centered medical home quarterback trying to influence nearly all of the expenditures so that the patient is getting the highest value, best quality, most seamless care through the system. We think that this will improve access to primary care, extending beyond the normal business hours of 8 to 5 so that we have accessible care after hours and on weekends, and it can avoid the inefficient and frequently overutilized emergency room, that we emphasize prevention so that we can avoid healthcare issues where possible, and that we actively manage the chronic disease of others. I think what's really important is this is a different mindset. We as physicians, clinicians, we're not really trained in what we're asking folks to do in the patient-centered medical home. Primary care clinicians get up and they think about what they are going to have on their clinic roster to actually have to deal with in terms of, I say, numerator events. It's what the clinic list is of visits of people that are coming in today. This is actually asking that team, not just the physician, but the team, to think about what is our panel of patients and what do they need, whether or not they're coming in for a clinic visit. How do we do care coordination? How do we make sure that the diabetic who we have not seen in 2 years is actually got an outreach coordinator who's pulling them in so that we can avoid some of the downstream negative comorbid conditions that are associated? So I think it's important to go through that there really is a team-based panel management aspect here that extends beyond the 4 walls of the doctor's office. This is about community outreach, care coordination between provider visits, and active management of the folks in the state. 50% of our citizens have a chronic condition. If we don't actively manage that chronic condition, we will end up having much higher needs for use of services, and we think the patient-centered medical home is the best strategy to do this. And all along, an emphasis on quality of care, on stewardship of resources, and for paying for results. What's the result that the patient and the system need and want, not what's the volume of services that have been provided to the individual to generate payment. So with that as an overview of where we're trying to take our patient-centered medical home, and we have multi-payers in this. We have Medicare, we have Medicaid, we have Blue Cross, we have Qual Choice, we have United, who's committed on the university system side, we have Humana. All the payers are aligning to support the primary care clinicians in the same way as we move over time. I want to ask Randall Hunley to come up. He was one of the first pilots with Blue Cross Blue Shield. If you'll come up and share where you all are and what some of your experience has been, that would be great. Thanks, Randall.
Well, good afternoon. First, I must say I'm here not as a practicing physician, but who's really done these things, but as a medical director who has been involved in implementing a medical home and working on CPCI in several clinics. So I can't really take credit myself for any of this. And when you hear me use the word we, that's the big we as a group. And I have to say that the yeoman's work of administering what we've done has been through Courtney Matlock, one of my colleagues. You know, we do have experience with implementing one medical home and with several CPCI clinics. I am a member of the Payment Initiative PCMH Strategic Advisory Group, although I'm here not to talk about that, but rather about our group's experience with previous projects. Although I will say that group has been very engaged, and the Payment Initiative team has really listened, and a lot of what's being done is coming from that group. As Baptist Health Clinics, we were fortunate in 2010 to have one of our clinics selected to be a part of the Blue Cross PCMH pilot program, and that was our clinic in Bryant, Arkansas. We also had 15 clinics selected to participate in CPCI, which I'm sure most of you know is the CMS Innovation Center Comprehensive Primary Care Initiative, which is the multi-payer collaborative which pays a per member per month fee to clinics who are then expected to meet certain milestones to move them toward the PCMH model and ultimately, hopefully, to participate in shared savings. So that's the experience that I'm speaking from. What I'd like to hit on in the few minutes that I have is just a few of the milestones that we have dealt with, not all of them, but just a few and some of the experiences we've had. When the clinic started working on this project in Bryant, one of the first things they did was to look at access, really taking an objective look at the clinic schedule, the open slots, the scheduled slots to determine the best arrangement, as well as looking at extended hours to meet the needs of the patients. A huge part of this concept, which has already been alluded to, is the team-based care. Now, that term is thrown around a lot, almost to the point that it's become meaningless, but I will tell you that at least in our Bryant Clinic, which is the furthest along, there has been a real sea change in how the staff think about their jobs. I think traditionally the staff in a physician's office saw themselves as there to assist the doctor and get patients in and out, et cetera, but now everybody in that clinic, from the front desk to radiology to the medical assistant, sees himself as part of a team. And part of that has come through implementation of daily huddles, at which the day's schedule and the patients who are being seen is discussed, as well as other patient needs that have come up. Also, they have implemented a refill protocol, which is part of the clinic policy, and it makes it possible for anyone who takes a patient call to follow certain steps and promptly make a refill, and just as importantly, to make sure that appropriate follow-up arrangements have been made. Another thing that's already been alluded to is this concept of population management, which is a huge change in the way practitioners have always practiced. Traditionally, we're focused on the patient in front of us at that moment, whether it's in the hospital or in the clinic, and answer some phone calls, and otherwise patients are on their own. But part of this concept, which has been started in Bryant and is also now being implemented in our CPCI clinics, is the population management, in which we will have care coordinators who reach out to patients, who check the health records for missing tests or procedures or visits, et cetera. And that's based on a risk stratification scheme that our providers have agreed upon, and assign a risk score to each patient so that the care coordinators can focus on the right folks. Another huge part of this is referral tracking. I think we all know that traditionally one of the big holes that we have has to do with making a referral to a specialist or for a test, and the patient doesn't go to get it done, and we don't know that until they come back, if we ever find that out. And through the medical home, clinic implemented a log for all patients having either high-risk referrals or studies. And actually, there's kind of a nice story here of a patient who had been scheduled for a CT scan of the chest. I don't recall the reason. The patient didn't show up to have it done. Someone in the office realized that hadn't been done, reached out to the patient, called them, expressed concern, rescheduled it, and incidentally, the scan showed a renal carcinoma, which was local and which could be resected. So that's something that I think we can all identify with that type story. Another huge thing that has been subject to focus is the transitions of care from the emergency department to the clinic, and medication reconciliation at discharge, and even knowing when a patient has been in the hospital. That's still a challenge, one of our bigger challenges, but obviously something that we need to conquer. There are a lot of other milestones, such as shared decision making and other things, but I won't go into those. Just wanted to touch on a few of them today. I think providers wonder what's the effect of this type program on their daily life and workload. I will tell you this does require some effort and commitment and a real change in the way we think about practicing medicine. Most of our physicians tell me that, the workload is really not much different, better or worse, but many of them feel some increased satisfaction in knowing that their panel of patients is being looked after 24/7. Obviously, we're interested in the cost and quality. Truly, I think it's too early for us to have good data. We are trying to look at some data. The care coordination aspect has only been implemented very recently, and I really feel that that's probably the biggest element that's going to contribute to cost savings going forward. And, finally, let me just say, I think we're all very aware this is a time of rapid change, dizzying change, really more change in almost every aspect of medicine than we can be expected to deal with. But it's also a huge opportunity for primary care to step up and take its place as kind of the center, the true medical home And, I think if physicians do step up, they can grab this bull by the horns, but otherwise the train will probably leave without us. And finally, having practiced interventional cardiology for a long time, it's been pretty interesting to me to transition into more of a focus on primary care, but I must say it couldn't have happened at a more exciting time. Thank you.